Good afternoon. Thank you for the opportunity to talk about the Acute Care Health Services Research Unit. I want to tell a little bit of a story about this. So I conceived of this idea somewhere in 2012, and then I had my meeting with Dr. Newmar in December of 2012 when I interviewed here for a faculty position in adult EM. And it's been a while since then, and we've been at it trying to get this, what was initially maybe a center and now a unit instituted, and now it has come to life. So before I start talking about what this unit is, I wanted to thank Dr. Newmar and Dr. Barsan for their support behind this idea. This unit is going to be an Acute Care Health Services Research Unit under IHPI. And it is a unit where we bring in researchers from various disciplines to conduct multidisciplinary policy-relevant research around acute care. And so acute, we have this kind of access, cost, utilization, transitions, and efficiency around acute care that we'll be studying in this health services research unit. Now, what I want to point out is different about the idea of this research unit is that right now across the country, there's various people in various disciplines who are studying different aspects of acute care. And they're doing this in silos. So ED docs are doing their own thing, and then inpatient docs and hospitalists and surgeons and anesthesiologists are doing their own thing in the inpatient setting. And there's folks who are studying the various aspects of acute care delivery in the pre-hospital or ambulatory care kind of settings. But the idea for this unit is to bring everyone from across these disciplines who has skin in the game, who's studying these various kind of questions around acute care to the table so that we can be talking and communicating and collaborating on projects that are pertinent to questions around acute care. So one of the things that we'll be doing in this unit is directly seeking questions that are pertinent to our own healthcare system. And the idea behind that is not only to be responsive to our own needs and our own challenges, but to use the preliminary data from studies in our own healthcare system to apply for larger grants and extramural funding to do multi-center kind of national level studies to address issues related to acute care delivery. So right now we have some core unit members, so I'll be leading the unit. Jason Goldstick, who's here today, is lending his statistical expertise. And we have a full-time research associate who's not here today, but he's Ricard Taymor. And beyond the core members of the unit, there are many people across campus who've expressed interest in participating in this unit, including 6 different departments in the School of Medicine, including family medicine, psychiatry, OB-GYN, internal medicine, surgery, and many folks from emergency medicine, and also from various different schools across campus, including social work, nursing, health policy, law. So there is plenty of interest in this unit, and we hope to get a lot of collaborators involved in the unit. So there are already a couple of ongoing projects under this virtual unit, and these are all funded projects through extramural funds. The first project is evaluating the impact of high occupancy hospitalizations on outcomes for elderly Medicare patients, and this is a project that is funded by the National Institute on Aging. And the goal of the project is to understand how outcomes for elderly Medicare patients are impacted when the inpatient units are really full. So we have a good understanding of how ED crowding impacts patient outcomes, and no matter which outcome you look at, ED crowding is a bad thing. And the central idea behind this proposal, which is going to be completed, it's an R21, it will be done in about 2 months, is to understand how crowding on the inpatient side impacts outcomes. And I'll be presenting the results of this project at the Internal Medicine Grand Rounds in June for anyone who's interested in coming. The next project is evaluating patient-centered interventions to reduce pediatric asthma-related emergency department visits and hospitalizations. This project is funded by the Emergency Medicine Foundation, and it is a collaboration with the Camden Coalition of Healthcare Providers, who are a group in Camden, New Jersey, who do hotspotting. So they identify people who are super utilizers of acute care, including ED care and hospitalizations. And they aim to develop interventions to reduce acute care use, improve patient outcomes, and save healthcare costs. And the last project is a mixed method study to evaluate performance measures for Medical Control Authority for the state of Michigan. This project is funded by the Michigan Department of Health and Human Services, and it is a mixed method study to really give policy recommendations to the state to decide what to do with the existing 65 medical control authorities that run EMS in our state, and what even defines a successful medical control authority. I want to mention that all of these projects are collaborations between multidisciplinary groups of researchers here at Michigan and also at the RAND Corporation, which is a think tank located in Santa Monica, California. So what is this unit ultimately going to be doing? At the most basic level, it's going to bring people together. So we're going to have quarterly meetings for members to come to promote collaboration, present key policy issues and research priorities, discuss member ideas for proposals and ongoing projects. Number two, identify intra and extramural funding opportunities. So the idea for this unit is to ultimately become a grant writing and submitting machine to bring in extramural funds. And the idea is to have almost a rapid response team who is looking out for opportunities to submit grants around acute care. Again, in the context of researchers that have already become familiar with each other and have a working relationship. And the last one, which I'm very excited about, is quarterly student and trainee conferences with med students, graduate students, and residents and fellows to promote interest in acute care research and related policy issues. So with that being said, I want to go on to one of the projects that the unit has just started that I didn't include in the bulleted projects that I just talked about, evaluating ambulatory care sensitive emergency department visits and hospitalizations at the University of Michigan Health System. And this is a collaboration with Jason Goldstick and Tim Peterson, who's holding the fort in the ED right now, so he can't be here. So the idea for this project came from Jeff Desmond's talk at the faculty meeting, I guess it was now 8 months ago, 10 months ago, and where he talked about some of the priorities of our healthcare system. And among those priorities, we're really evaluating and understanding ambulatory care sensitive ED visits and hospitalizations in our own healthcare system as a way to be able to come up with interventions to reduce those visits via, for example, improving ambulatory care capacity and access. So I'm going to be presenting the very, very preliminary results of this study that is also going to be a mixed method study. So for those of you who are not familiar with ambulatory care sensitive conditions, these are a set of conditions that ultimately, if treated appropriately in the ambulatory care setting, someone should not be presenting for care in the ED or get hospitalized. And it includes about 40 ICD-9 codes comprising about 30 different conditions, including cardiac, so angina and CHF, pulmonary, including COPD and pneumonia, GU conditions, including invasive cervical cancer and UTIs and pyelonephritis. Under infectious, there's also cellulitis, nutritional like iron deficiency anemia, and dental conditions. And in the state of Michigan, between 2008 and 2012, rates of hospitalizations per 10,000 population for these conditions for all ages was approximately 268. So this is a pretty high burden. So our study is a retrospective observational study using ambulatory care, ED, and inpatient data from electronic health records from our own healthcare system for a 20-month period between 2012 and 2014. So from the inception of my chart and onwards for 20 months. In patients 18 years and older using ICD-9 codes for ambulatory care sensitive conditions, we have evaluated the percentage of ED visits that are billed for ambulatory care sensitive conditions and proportion of those visits that are preceded by an ambulatory care visit in the prior 2 weeks, and also percentages of hospitalizations and any preceding ambulatory care visits in the prior 2 weeks. And the reason why we care about these, so first of all, right now we don't have the knowledge of what the burden of these visits are and this acute care utilization is in our healthcare system. So at the most basic level, what is the burden of use? And number two is, are these people who are presenting to our ED and getting hospitalized, have they been seen in the ambulatory care setting within the prior 2 weeks, which would be appropriate, or not? So we found that almost 89,000 ED visits met our inclusion criteria. Approximately 19% had an ambulatory care sensitive related ED visit. Among patients who had such visits, 20% were seen in the ambulatory setting for any condition in the 2 weeks prior to their visit. and 12% were seen in the ambulatory setting for an ambulatory care sensitive condition in 2 weeks prior to their visit. So no matter which one you look at, all comers versus for ambulatory care sensitive condition, only a small percentage of folks who end up in the ED or hospitalized with these conditions have been seen in the appropriate setting before presenting. So there's a lot of room to come up with interventions and intervene on this. And for UMHS ambulatory care sensitive hospitalizations, there is almost 391,000 hospitalizations met our inclusion criteria, and about 25% had an ambulatory care sensitive condition related hospitalization. Among patients who had such hospitalizations, 36% were seen in the ambulatory setting for any condition in the 2 weeks prior, and 30% were seen in the ambulatory setting in the 2 weeks prior to their hospitalization for an ACSC related condition. So ultimately, again, this was very preliminary data. This is a study that aims to further characterize what these ED visits and hospitalizations are comprised of. So which conditions are driving these? We imagine that CHF is going to be on the front line here, and we're going to see who are these patients, what is their profile, and also ultimately through a qualitative piece, evaluate barriers to improve management of ambulatory care sensitive conditions in the ambulatory setting in collaboration with family medicine and internal medicine, and coming up with potential related strategies. Thank you.
You've done amazing work in your just few years here, putting all these together. Questions? We have time for 1 or 2 questions.
Hi, first I want to congratulate you on the new unit. It's obviously a testament to the amazing work that Rebecca was just bringing up. Self-servingly, I saw the part about educating our residents. I know for a fact in talking with them that the kind of work you do is something there's a lot of people that are very passionate about. Have you had more chance to think about how you're going to involve them in those didactics and what roles that our residents can play in that? Because I would say a third of the people I talk with on a regular basis that have an interest in research are interested in the things you're kind of doing, but you're doing it on a scale and in a way that is it's just very impressive, and it's the kind of expert nationally kind of stuff that our residents, while they're here at Michigan, should be a part of, if possible. So thank you. It's more of a statement, I guess.
Well, I appreciate all the compliments, John. Thank you so much. Well, the answer really is that residents and medical students are welcome to be involved on just attending these meetings or being involved in setting them up and actually being active in the unit, coming up with topics to discuss, and also being parts of my projects. I've met with a couple of residents already who are interested, and I'm always open to including folks, so my door is always open.
That was great stuff, Mahshid. It was a great presentation as well. So one of the things, even though there's a fair number of these patients who were seen in the ambulatory setting within 2 weeks, there's a fair number of them who more that hadn't been seen. And it brings to mind some of the stuff Kevin was talking about some of the fancy home devices and stuff for monitoring or things that might help to sort of bridge patients. And, just curious as far as, your plans, looking at any of those, or how do you get more patients evaluated?
Sure. So the entire intention between any research that this unit does is that for it to actually have impact and change things and change the way we do things. So you're really alluding to at least one piece of interventions that we can think about, and which is home monitoring. And both Kevin and I have been in conversation, and I submitted a grant with Care Innovations, who is GE and Intel, and have every intention moving forward to take these ideas and go beyond just hypothesis and say that, okay, we've defined the problem, what's the solution, and actually pursue grant funding to implement the solutions.
Now it's working. So my question is, what do you know about the reason why those 70% of people that ended up being admitted didn't have an ambulatory care visit in the 2 weeks beforehand? Did they try to and were unsuccessful? Did they just not bother to try? Was it an acute event that didn't just happen that same day? And if you don't have those answers, how do you find that out?
Sure. So very, very important question. So this is where, using the data that we have, unless we do pretty serious chart extraction of data, which is probably beyond the scope and budget that we have for this project, probably the quickest way to come up with some kind of buckets of reasons why people are showing up and not having visits is doing qualitative work. So the qualitative work that we're envisioning is not just with the care providers, so including us, including family medicine, internal medicine, to understand some of the barriers behind why people aren't seeing in the right setting, but also talking to patients to say, you know, was it the fact that you don't have a PCP? Was it the fact that you have one but you couldn't get in because you have 3 jobs, or that there's no evening hours or weekend hours? Or the fact that you actually have a PCP, probably could have gotten in, but still came to the ED, which is an interesting bucket of a culture of ED use. So I anticipate that the first step is going to be pretty heavy qualitative work to understand what's behind it, and that is largely going to inform interventions.